name is Melanie Rogers. I'm the founder and CEO and certified eating disorder registered dietitian at Balance Eating Disorder Treatment Centre. And joining me today is the wonderful Blake. Blake, would you like to introduce yourself?
I would love to. Thank you for that, Mel. I am Blake Biddle. I'm a dietitian at Balance Eating Disorder Treatment Center, and we have a webinar today for you about orthorexia.
So without further ado, because I know we're a couple of minutes late and I know that I'm just looking as our guests and participants join us. We've got quite a number of people joining us today, so I'm just looking as people are still coming in there. While we're doing that, I'm going to bring up our slides, Blake, so that we can start our presentation for today. Just one sec while I bring that up.
Sure.
Okay. Can you see that okay, Blake? I'm just taking it, I'm now moving it to the presentation screen. You can see it okay?
Yep, I see it great.
Terrific. So our title today, which we're super excited about, Orthorexia, when healthy eating goes too far. And today, Blake and I are going to be walking you through an overview of orthorexia and what it is, and specifically focusing in on disordered eating as a component of that. And this webinar today is part of our Balance webinar series for the new year. So welcome to 2021 in January. So without further ado, our overview for today is we're going to identify the difference between non-disordered neutral eating, in other words, AKA normal eating, and orthorexia. What's the difference there? I have some similarities, but they also have quite a few differences. We also today, hopefully you'll leave with an understanding of how diet culture plays a role in influencing the rise in orthorexic behaviours. We're going to be looking at those who are at the greatest risk for developing this type of eating disorder, albeit it doesn't have a full diagnostic code, and we'll speak to that today as well. And also, we'd like to go over a few resources with you, and also take a little bit of a look at how do you treat this type of disordered eating disorder. What are some of the techniques that are used? Can you actually recover from it? Can you, if you are struggling, does it mean you're destined to struggle with orthorexia for the rest of your life? So we'll be walking through some of those with you today. So orthorexia, it's come to be known, it's actually called orthorexia nervosa. It's come to be known as an unhealthy obsession with otherwise healthy eating. So the question is, is it clean eating? And I think in current society, when we think about clean eating and when it's used in social media and just in, conversation, really, it's a proxy or it's a default phrase to mean being healthy, right? Like if I'm eating clean, we tend to think that means I'm being healthy and I'm in good health. Healthy eating, same deal. So what is orthorexia then? Is it something that's super healthy? Is it a lifestyle syndrome, or is it actually something else? And actually the phrase orthorexia was first coined by Dr. Bratman back in the 90s. And as it was actually through some of his research, he started to see some patterns among a certain population, and actually the population he started to see this most prevalently amongst was people who were practicing yoga, which was quite interesting. And so what he saw were people were utilizing or following extreme diets or meal plans that were intended for health reasons, but in fact were leading to severe and significant malnutrition and then impairment of daily functioning. So in that essence, not healthy at all, though the intent behind it started out from a very healthy place. So we've got a couple of case studies here to really kind of highlight for you what this looks like and how it might be different to healthy eating or restrictive eating. And Blake's going to walk us through these two case studies. Over to you, Blake.
Thank you, Mel. So yeah, like Mel just said, These will really show you the difference between when it becomes a full-blown eating disorder and when it was a desire to improve your health in some way. Both of these case studies are pulled from a literature review that was done by Dunn and Bratman. So the first one that we have here is a female client who began her restrictive eating at 14 years old when she went to see her nutritionist because she was concerned about acne. So when I see that, I think a teenager going through puberty who is concerned about her acne, right? But this nutritionist said that it might be best for her to restrict fat from her diet. She put her on an elimination diet. From there, this person progressively restricted their diet more and more. So at age 16, she decided to become a vegetarian who does include eggs and milk. So that's lacto-ovo. And from there, eliminated eggs and milk products, becoming entirely vegan. So you'll notice that all of these animal sources are things that do contain fat. So she's still following with that original recommendation. By the time she presented to treatment, her BMI was 10.7, and it had been 14 or more than 10 years since she originally started restricting her diet. So for those of you on the call who are not clinicians, the underweight category of BMI is actually 18.5. So we see a really stark difference there between borderline underweight and how this client ended up. The hallmark of orthorexia here, rather than anorexia, is that she didn't report any desire to be thin or distorted body image, but she presented with an original concern, which was, I have acne, how do I fix it? And then transitioned into believing that these foods might cause her either continued acne or to develop toxins in her body. I do want to highlight something here is that these professional elimination diets can become so concerning if they're not very closely followed up. And it's really important that if someone is put on one of these because of perhaps allergies or food sensitivities, that they're followed up very, very closely, because this can be really common and we see this very often in our practice.
Blake, I just wanted to absolutely highlight that for our viewers today. I think that's actually one of the most common presentations that we see, isn't it? Where we have clients who want to see a specialist. Again, the intention is good, is there anything we can do for my acne or whatever it may be that might be concerning them? And they're put on some type of elimination diet, but then there's not good follow-up.
Mm-hmm.
And then things start to really get out of control. And
Mm-hmm.
then we see that client presenting when things are really severe and significant. So no, that's a great example. I'll move on to the next slide for you.
Sure. Okay, so the next slide is a male client who's a bit older, he's 28. He restricted his diet for 3 years before treatment. And his original concern, or the reason that he began restricting, was in response to constipation. So he began creating his own protein shakes because he was concerned that commercial made shakes or shakes that he might find in the store would contain fillers. So this is something that we see commonly, which is a lack of trust in the food environment, that someone is going to put something in the drink or food that will harm him in some way. So of course, if you're subsisting off of only protein shakes, there is going to be severe malnutrition that's resulting. So by the time he presented to treatment, his BMI was 12.3, or about half of his ideal body weight. So I know that BMI and ideal body weight are not the best measurements that we usually use for health, but when we're pointing out malnourishment and being underweight, they can be really helpful to just show us the severity. So the client really was focused on the purity of his diet, stated that his body was a temple and he did not want to put anything in his diet or in his body, that would be unpure. So that's why he created his own protein shakes to make sure that this concern was met. All right, so we can go to the next slide. So as you can see in these two case studies, orthorexia can result in really severe malnutrition and even death in severe cases. First, we will often likely see anemia and vitamin deficiencies. It's important to note that these can occur often without presence of weight loss that's measurable. So these can occur in anyone with any size body. Then when it gets more severe, we will see muscle wasting and organ wasting. Eventually also bone loss or like osteoporosis, osteopenia. Um, the organ wasting is something interesting because you won't be able to test that from the scale. You won't be able to see that as someone who is just concerned about your health. But if we're losing lean body mass, we're often damaging our organs like our liver or our heart.
Absolutely. And Blake, I wanted to highlight, and I think you touched upon it there for our people who are listening. Those two case studies were for people who ended up at a very low weight. That if you were to observe them, you would know that there was something scary going on for them. But to your point, for our clients who may be in a higher weight body, if they were to pursue more orthorexic eating, which ends up eliminating certain foods, which ends up cutting calories, and they lost weight, but they were still presenting in a higher weight body and not hitting these super low BMIs. These side effects are still very, very relevant, because it's about the amount of weight loss per se, not the end weight, that is indicative of the harm that we're doing to our bodies. So, in diet culture, we congratulate people who lose 50 pounds or 75 pounds or 100 pounds, goodness, but anyone who's losing that weight, that type of weight, any weight actually, but those sorts of significant amounts of weight are going to be seeing these medical detrimental effects as well. So I just wanted to highlight that it's not end weight specific as well.
Mm-hmm.
So thanks for walking us through that, Blake. Incidence, over to me. So incidence is, wow, it's across the board, because we actually still don't, we're still, it's with any new observation of an eating pattern in this case, until you have specific criteria, so we're comparing apples to apples, it's hard to get a sense of incidence. So hence the range here is from anywhere from 18 to 83% in certain populations, because we don't have a consistent way to measure it. But we are seeing a lot of this sort of thing. And for anyone who's on Instagram, you will see a lot of this on social media as well. All those perfect meals. Excuse me. So as we said, we're not able to accurately measure and validate yet. However, we have identified some higher risk populations, which maybe is not surprising. Nutrition students, and both Blake and I are registered dietitians. So our field has a higher risk to develop orthorexia, which makes sense because, if you're studying food and you're studying health, it makes sense that many of us are motivated to therefore optimize our own health as well as those that we work with. So it does make sense that we start to kind of play around with this sort of thing and may end up getting into a more obsessive relationship than we ever, plan to develop. Medical students, perhaps for a similar reason. Musicians, which is interesting, and that was based upon musicians often, for example, taking dairy out of their diet for phlegm production and this sort of thing. So I thought that was very interesting. And then going back to our yoga practitioners, particularly from the Ashtanga group. So a little bit just to touch upon for us RDs, for those RDs who may have joined us or those nutrition students who might be joining us today, orthorexia has been defined as a fixation on righteous eating. This is the best way to be eating, and I'm, I guess, morally superior because I eat this way. So there was a research brief actually in the Journal of Anorexia Nervosa, Academy of Nutrition and Dietetics in 2017, where it said that both orthorexia and eating disorders are more common among RDs than the general population. And in fact, of 2,500 surveys given out, they had 636 responses to that. And this is what they saw, that 49.5, nearly 50% of the respondents were at risk for orthorexia. And that's based upon a survey using something called the Auto 15, which is actually orthorexia survey based on 15 questions. Nearly 13% are at risk of an eating disorder, and that's based upon another specific questionnaire, the EDE, that looks at eating disorder behaviors, and then 8.2% self-disclosed treatment for an eating disorder. If you look at population prevalence, you can see that these numbers are pretty much through the roof. So what that says to me is we need to be careful within our own fields and check in with each other. And certainly we should be putting this out on the table and discussing it openly, because we have a high risk group of people who are joining the nutritional field and medical field, and certainly, you know, for those who are practicing yoga, as we saw earlier. And again, this is a really interesting graph here where we're looking at maybe this is really a job hazard for RDs. So on the left, we have the general population. In the green, the percentage of the general population with an eating disorder, which is just under about 10%, is the current prevalence estimates. In the kind of orangey color for orthorexia, you can see there in the general population on the left side, and then the yellow is so-called normal. And on the right side, for dietitians, we have a much higher percentage risk of eating disorders, extremely high percentage for orthorexia, and less so for just regular normal eating. So, you know, guys, if we are out there giving advice to clients, we need to make sure that we're in the best neutral place with food in our bodies as well, which means we do have a responsibility to be looking at our own behaviors around food. So disordered eating on a spectrum, we're often asked, right, Blake? All right, well, what is normal eating anyway? And so why is this so different? And it's so normalized in our society. So, you know, please help to clarify. So the way that I try to conceptualize this on a spectrum is on the left-hand side, we've got so-called normal eating, which can mean different things for different people, but it's a combination of different things that I've tried to identify here. First is a neutral relationship with food, which at balance, right? We talk about this so much. A neutral relationship with food is, believe it or not, we don't label foods as good, bad, healthy, unhealthy, clean, unclean. We try to take away all labels. Food is just food, which falls into the next point here of all foods fit. What that means is that my Doritos are just as important to my meal plan as is my kale salad or my sushi or my pizza or my burger. It's just food. And I know that that is very counter to the messaging around the nutritional density of foods, but we're not talking about the nutritional density of foods. We're talking about the idea of foods, all sorts of foods, giving us pleasure, and then it's really a balance of those. Intuitive eating, I'm sure many of you have heard lots and lots and lots about intuitive eating, which is really about eating from a place of your true hunger and your true fullness with satiety and your true food preferences playing a role. So there's kind of 4 parts to that. And intuitive eating is not magical. It's really about getting back in touch with your internal regulatory system that we're born with, a very, very sophisticated system that's controlled between the gut and the brain around and other areas of the body that are combined, come together to work together to optimize our weight and therefore to optimize the health of our body. So it's all interrelated. And an example of intuitive eating is if anyone's been around a newborn baby, how does a newborn know that they need to eat? You know, they don't have a calorie measure on their arm that says, okay, we need our 4 bottles of calories today because I'm running on empty. No, it's beautifully set up to tell us that if we're hungry, we get a sensation of hunger. Babies cry when they're hungry. You feed them. If you try to feed them more than they need, they will spit it out. They're full. So that is the beauty of this wonderful regulatory system that we're born with, that when we start dieting and we start messing around with our food, we totally mess it up. And so it's really getting back in tune with that. That is the best way to then optimize your health because you're eating from that from that internal regulatory system that's specific to you and your body's physiological needs. And mindful eating is a piece of that, which is actually tasting your food, not inhaling it. We all inhale our food, don't get us wrong. In front of the TV, in front of the computer, you know, we don't take lunch breaks, we're eating on the go. We get it. But mindful eating is at least touching base with, do I actually even like this? And am I full and I can stop eating right now instead of just eating beyond fullness? All right, so that is kind of some of the ideas around normal eating. And if we're blowing your mind, you know, please, you know, pop some questions in the chat box. We'll take those later. Disordered eating. Okay, what is that? And I am not suggesting that anything here in the purple box, if you're following any of these styles of eating, that you therefore have disordered eating. I am not saying that at all, but I am saying that you could be at risk for disordered eating because we know that once we start to play around with our macronutrients, our carbs, our protein, our fats, how much, it can start to get obsessive really quickly if you have that inclination. So disordered eating, any of these types of, and you know, any of these types of eating styles, and if you go to Barnes and Noble or any of the bookstores or go online to Amazon and you know, type in eating diets, you will find many, many books under each of these categories, unfortunately. All right, so then we go, but I think what I want to highlight with disordered eating is that it starts to get obsessive and it starts to get a bit distressing. So for example, if you're following, I don't know, a vegan diet, which is perfectly fine, but it prevents you from being able to go out to see out to a friend's house because it becomes a big deal. Or if you're so focused on clean eating that you're not able to eat at a restaurant, so you stop socializing with friends, pre-COVID, of course. And so some of these day-to-day social activities become problematic for you, or maybe dating becomes problematic for you, or eating with the family becomes problematic. Those are the sorts of flags to kind of stop and ask the question, is this balanced? What's going on here? An eating disorder then is when things go from distressing to problematic and start to be disruptive to relationships, to family, to work, to school, and to your health. And so many people, I'm sure, are familiar with anorexia, which is when we lose a lot of weight and end up at a very low weight. Bulimia is when we're restricting, we're then overeating, and we're then often vomiting. Binge eating is when we're often restricting and then overeating. And ARFID and NOSFID and binge eating actually are all new diagnostic codes we got in 2013. But ARFID is known more like picky eating, is a way of thinking about ARFID, where people have problems with textures and avoid certain foods because of that, or a fear of choking. And OSFID is a kind of an umbrella term whereby if symptoms are not as consistent over 3 months that meet criteria for bulimia or binge eating disorder, but they're still severe, they are given a diagnosis of OSFID, which is other specified food and eating disorder. So let's have a look at the box below that though, because these descriptors, I guess, are eating disorder behaviors that we've observed enough of clinically that we actually have a name for them, but none of them have a diagnostic code yet, which means we're still gathering more evidence and information around them. And the first one, of course, is orthorexia, which today's presentation is all about, because it's not just disordered eating, it's getting into the position of completely disrupting people's lives, as you saw in those 2 case studies that Blake walked us through. And for those who may be interested in these other categories, diabulimia, we see this with type 1 diabetics who are not using their insulin, not administering insulin properly, and therefore they are trying to lose weight through peeing out excess blood sugar, very, very dangerous. Drunkorexia, often seen in our college population, whereby students, often female, cut back on eating so that they can use their calories for alcohol when they're out partying. Pregorexia, horrible term, but it's really when a female goes through pregnancy and the whole change in body and hormones creates an uptick in eating disorder behaviors. We've actually had 2 or 3 clients over the last couple of years who saw such a severe uptick in eating disorder behaviors that they joined our program, our full day program, 30 hours a week for 9 months to get them through to a safe pregnancy, which also shows you how these illnesses totally hijack the brain and it doesn't become rational around health anymore. Because, one would beg the question that if you're pregnant, wouldn't you do whatever you could to protect your baby and make sure your baby's healthy? But the fact that our clients struggled with that again shows that it's not rational. Bigorexia, unfortunately, this is affecting our guys out there, which is very much around muscle dysmorphia and needing to be big and getting pumped up, etc. All right, so that's an overview, guys, about how we conceptually think about normal eating to disordered eating to eating disorders. And as you can see, orthorexia is tucking in there under a category as a full-blown eating disorder because it can lead to such impairment. All right, diagnostic criteria for orthorexia. Blake, I think you're going to walk us through that.
Yes, I am. All right. So I also wanted to point out that that second case study that we reviewed, the male client, he was actually diagnosed with, well, what used to be EDNOS, but it's very similar to OSFED. So we don't have diagnostic criteria at this moment in time for orthorexia. And these people are unfortunately not being diagnosed with their accurate eating disorder, which makes it difficult to treat. So when the DSM-5 was being created, there was a paucity of research for the incidence and evidence-based treatments for orthorexia. So we shouldn't hold our breath because the DSM-5 came out in 2013. So I'm not imagining that we'll get a DSM-6 anytime soon, but it makes it a lot more difficult to treat these people who need help if we don't have diagnostic criteria. So Morose in 2015 in the Journal of Psychosomatics, which is a psychiatry journal, proposed a 6-part criteria. You can go to the next slide, Mel. All right. The first criteria is a obsessional preoccupation with eating healthy foods. As you saw in our case studies, oftentimes a focus on purity or like the building blocks or simplifying our intake, right? And then 2 or more of the 7-part diagnostic criteria. So consuming a nutritionally unbalanced diet, I think it's important to note that therein lies a difference between healthy eating and unhealthy eating. If we are focusing on trying to improve our health through our food, that's all well and good, right? But if we're restricting so much that our diet is no longer balanced and we're not getting what we need, that's when it becomes concerning. Preoccupation, rigidity, an avoidance of foods, especially preservatives. This has been really popular in diet culture lately. People talking about like being able to pronounce our ingredients and things like that. This has become a really prevalent concern in people in the clean eating community, which then can become an eating disorder. Go to the next slide.
And people often saying, if I can't pronounce it, I'm not going to eat it.
Yeah, that's a big one too.
That's kind of the litmus test.
Mm-hmm.
And I get it,
Yeah, absolutely. That's so understandable. But then oftentimes, if we have clients that are concerned about this, I'll ask them to, okay, go to your nearest pantry, find me something in your pantry that feels safe to you. Let's look at the ingredients. Let's break them down into what they truly are. And they might be things that are so simple that they just have a chemical name on the back.
Right, like sodium chloride, right?
That's which is just salt.
That's actually salt. That's just the composition of salt.
Yeah. Spending excessive amounts of time reading about, acquiring, preparing, or thinking about food. This can be, of course, as a really big hallmark of an eating disorder, but can also be an indicator of malnutrition in and of itself. When the brain is not receiving adequate nutrients, that's what it's going to start thinking about. oftentimes we will ask our clients in an intake process, how much time do you spend thinking about your food? Is it more than 3 hours a day? Is it more than 20 or 50% of your time? And that can help clients to understand really the way that this is impacting their life. Um, Guilt after transgressions, if the transgressions even happen. Sometimes, if clients are really malnourished, they will binge on foods that are not allowed in their diet according to the eating disorder. That will cause some severe, severe shame. Intolerance to others' food beliefs. Mel was just talking about pregnant women, people who are parents, men and women, might start to enforce their beliefs on their children. So perhaps their family is now following some of these orthorexic tendencies. Um, People might also, if they're out to eat, say, "Oh, how could you eat that?" Things like that. Making comments, or I think what the colloquial term is like food shaming, right? Others. Spending a lot of money on your food, shopping only organic if you can't afford it. Um, just really living outside of your lifestyle, really. And the obsessional preoccupation, which impairs health. We can go to the next slide, and it says that it also impairs our social or academic lives. So we're trying to figure out, how is this impairing our functioning, really, is the concern. Section D tries to rule out an primary diagnosis of OCD. There are a lot of similar traits there, but if OCD is the primary diagnosis, it's more important. We need to treat that first and just be aware of that. And then E. So we saw in the case studies that medical exclusion can often progress to severe orthorexia. However, there are some cases where there are food allergies, right? Someone might have a lot of food allergies and their diet is really limited because of that. But this can progress, and it's something that we really want to be aware of. And there is a high incidence of people developing eating disorders who do have food allergies.
Absolutely. Oops.
Okay, so here we have a lovely chart that shows us the common traits and symptomologies among anorexia, OCD, and orthorexia. So since we don't have diagnostic criteria for orthorexia, which is unfortunate, we can draw upon disorders which are similar and which we do have evidence-based practices to treat. So you'll see at the top here that orthorexia, we have the focus on food quality and the unrealistic food beliefs. These are things that you just saw in the diagnostic criteria. The commonalities between anorexia and orthorexia really focus on the restrictive attitudes and maybe some guilt over food transgressions. Then we have egosyntonic thoughts here. Egosyntonic means that it is in alignment with self-image. The behaviors are helping us become something that we believe ourselves to be or want to be. So perhaps in orthorexia, the client would only eat clean foods, right, or pure foods out of a desire for purity, out of a guilt over maybe some other type of part of their psyche. I'll leave that to their therapist. In anorexia, this real true fear around being in a larger body is egosyntonic because we are restricting, therefore more than likely losing weight, right? It also tends to be egosyntonic with perfectionistic tendencies. So if I can only eat perfect, then I can be this perfect person, right? Contrastingly, you'll see over here in OCD that we often have ego dystonic thoughts, which are not in alignment with self-image. And these thoughts can be really distressing to the client. So with that being said, ego dystonic thoughts are oftentimes a reason that someone might present to treatment. They might have a lot of guilt or shame. And this is a reason that we often see people with bulimia presenting to treatment, because these behaviors are very aligned with shame. However, it takes a long time for people with egosyntonic thoughts and behaviors to present to treatment because they are perceiving that it's helping them become the person that they want to be.
Perfectly captured there, Blake. Absolutely. And hence, for the danger in that, right? As I'm sure people who are joining us today can extrapolate, is that we've got a lot of people walking around with orthorexia and with anorexia that is heavily impacting their lives and their health. But because it's in alignment with their image of themselves, they are not seeking treatment. And also if you bring your concerns to a loved one who might be struggling with orthorexic behaviors or anorexic behaviors, they're typically going to reject your input and concerns because, again, it's something that they feel is of value to them and their identity. Versus the OCD, as you said, there's an embarrassment around those sorts of behaviors. And I don't want to be obsessively compulsively washing my hands, even with COVID, or whatever the behaviors may be. So more inclined to seek out help. And that is a huge difficulty with trying to get clients to get treatment. And the earlier the better, because the prognosis is better. But as you can see here, there's a lot that works against that happening. Nicely summarized, Blake.
Thanks, Mel. Yeah, that might sound like from a client saying, I'll often hear it in mealtime, well, why would I eat this? Why would I finish this? I'm doing something that I don't want to do, and you're forcing me to do something that I know is not good for me, right? So it really requires a lot of education and a lot of unpacking of those types of thoughts.
Yeah, exactly. And hence the litmus test question that Blake referred to earlier that I use a lot, just a quick down and dirty, which is how much of your day are you spending thinking about food, calories, if in fact that's a factor, or purity, or weight, etc. But how much of your day are you spending thinking about food? And that can really give you a sense, when you're not distracted, by the way, and that can really give you a sense of if this is becoming obsessive. The average person who doesn't have disordered eating or an eating disorder, who just gets up and I'm hungry, I'm going to have breakfast, I eat breakfast, and then I don't think about food until I'm hungry again. That person, whomever they are, very rare, but they think about food about 15% of the day. That's 15%, whereas for disordered eating and eating disorders, it's 50%, it's 60%, it's 100+%. All right, and so orthorexia, as you could well imagine, if you are losing weight unintentionally, what we do know about the development of anorexia is that if you lose weight below a certain set point for your body, the current thinking is that genetically it may then turn on the actual full-blown illness of anorexia. So orthorexia unintentionally could lead to then a real fixation on calories and body image, even though it didn't start out that way. It came from a place of just health. So to be alert to that as well.
Yeah. So what we'll see is, since we saw those strong correlation between anorexia and orthorexia with the common symptomology, what we'll see is a switch from being concerned about quality to then being concerned about quantity once the disorder has become that severe. And we also saw this in the Ancel Keys starvation study, if anybody is familiar with that. It showed us the effects of food restriction on otherwise healthy men. And once they were restricted to about half of their intake, they had even further food preoccupation, and that body image component switched on. So the last thing that I do want to note is that it's very, very common for diagnoses to change throughout the course of treatment. With that being said, regardless of the diagnosis, anyone who is experiencing any distress caused by disordered eating, you are worthy of treatment, and it is worth seeking help. So this is my favorite handout created by our friend and colleague and mentor, Jessica Setnick. I love doing this with clients because it really helps us to evaluate, is your food restriction or food exclusion, productive or destructive? You can see here at the end of the arrows. And we take some time to evaluate these exclusions and how they are really fitting into our lives. Sometimes these questions require a lot of deep inquiry and education and perhaps reflection on the behalf of the clinician, because someone might not realize how much it truly is affecting their life. But we can use, for example, our 14-year-old in the case study who was asked to remove fat entirely from her diet, right? So, nutrition, can you stay well nourished without this component? Well, the answer right there is no, because she needs the fat to absorb fat soluble vitamins and to keep her organs cushioned and to create hormones and to keep her hair and skin glowing, all of the above. So we could put a stop right there, right? But we'll keep going. Is it relevant? Does excluding this make sense in your current situation? Are you able to do that? Are you able to find foods that are cooked without fat? Are you able to cook for yourself right now, or are you at work most of the day? Or are you excluding it just because of a trend? This could also be extended to the keto diet and juice cleanses, which are so popular right now, especially with the new year being around. I know that everybody is being subjected to a lot of advertising on social media and television around those things. So the relevancy might come up more than usual this time of year. Ability. You are prepared to exclude it completely without shame. Okay. So this is something I was referencing before. We might sometimes binge eat foods that we restrict from ourselves because our body is fully aware that it is being malnourished, it's being restricted. Ability also can touch on, do you feel able to provide for yourself with these foods? I oftentimes have clients who are vegan or vegetarian, and while there is absolutely nothing wrong with following a diet like that, they have a hard time finding foods they enjoy. And then their diet just becomes very, very restrictive, and it's they may lose weight, they may just feel very unhappy with what they're eating. So it's worth evaluating, is this something that I still want to exclude from my diet? Resiliency. Are you prepared for the occasional accidental glitch? I might ask clients, okay, so what if you went to a birthday party and you thought the cake was cooked without eggs, but it wasn't? Then what? What's our reaction? How much anxiety does that provoke? If it provokes more anxiety than we would like higher than like a 5 on the scale, then maybe that's some work to be done there. Balance. You can still have other activities and interests. One of the biggest hallmarks of an eating disorder, especially orthorexia, is the isolation from family and friends. If you are spending so much time thinking and preparing and shopping for food that you are isolated, or you don't have time to maybe work, or it's keeping you from doing your work in an appropriate way, that's time to receive treatment as well. And then the final result is, does this improve your mood, condition, or health? So perhaps you're allergic to peanuts and you're excluding peanuts. That improves your health 100%. We don't want you going into anaphylactic shock. But perhaps excluding it makes you anxious, sick, or depressed. This is usually switched for most people. So this is hard for people to understand, because I'll say to clients, does excluding this food make you anxious or depressed? And they'll say, no, you making me eat it makes me anxious and depressed. But what we will more than likely see is that if we take more of a bird's eye view instead of zooming in, the malnutrition and the restriction from food can be what is causing the anxiety and the depression. And once we're refed, we often have a more appropriate anxious response. So this is important to be done with a clinician so that you can really take a good look at this, how these are affecting your life.
Absolutely. And Blake, what was coming up for me is, under the second category, relevant, the lower box there, that you exclude it because of a trend or a celebrity or a past diet. That's where I think the impact of social media is really hitting us there, right? Mm-hmm. What are our influences? What are we listening to? What are we hearing about? And we'll talk a little bit about social media and the impact of that a little bit later on. But it's a great checklist, really, isn't it? Mm-hmm. Okay. Blake, I noticed we have a couple of questions, and I'm wondering if you're able to access the chat box and we can see if those are helpful to answer now or to wait till later.
Let's see. So some of the chat box. Okay, so we have a question from someone who says, I work in the UK in child and adolescent eating disorders. and getting into more and more orthorexia patients who then slip into anorexia. Also wonder about athletic eating, which is often on the edge of a slippery slope. So I think the question is around athletes and orthorexia.
Yeah, let's yeah, absolutely. And so there you go. Athletes are a beautiful example of where you're trying to optimize your health and your performance. So you might be cutting out a little bit of this, or not eating a little bit of that, or more of this, less of that. And with that hyper focus, which can come especially for athletes, right? Because if you're hyper focused on optimal performance, you can slip into the obsessive mode. So you can see that for athletes, actually, there would be a higher risk of going into more orthorexic eating. So really coming back to this checklist here, and what we often see with our athletes, whether they develop a full-blown eating disorder or disordered eating or orthorexia, is that often what happens is that the style of eating that they're now embracing starts to impair performance. And instead of getting faster, let's say as a runner, their desire is, faster to increase their speeds, they start seeing a dip in performance. And so that's when we can start to work backwards and say, this is actually not working for you. Here's a really extreme example. I was working with a client several years ago who was into marathon running, and she had slipped very much into anorexic thinking and a full-blown eating disorder, but was in denial of that because her belief was that being at a smaller weight enabled her to run faster. And it did. But for 4 years in a row, what she did when she was doing the marathon is, because she wasn't fueling enough, at mile 15 or mile 18, she literally collapsed and could not continue running because she had absolutely no glycogen stores left. So her time, while she was able to run because there was fuel in her body, was fast, but because she wasn't fueling adequately as an athlete should under those circumstances, because of a fear of calories, then she couldn't actually complete the marathons. So it took quite a lot to, and honestly, a lot of fear on my behalf of her having a heart attack on the track. But that's also an extreme example. So yes, be careful with your athletes, and also you have to be careful with the coaches and what the coaches, misinformation that coaches might be spreading, and also what athletes might be picking up from other athletes through social media that may not be the healthiest balance for them based upon this wonderful checklist here. Blake, is there another question or anything you wanted to add there?
No, I think you did a beautiful job of explaining that. I've had a very similar experience with clients, and it is terrifying to see how their disorder is affecting them athletically.
Yeah.
There's a question that says, Blake, can you repeat what you say to clients when they say, no, you making me eat is making me anxious and depressed? Yeah, absolutely. So I'll repeat it and I'll add a little bit more. I tend to explain to clients when we have that conversation that in eating disorders, the neurobiology becomes such that our fight or flight response becomes a little bit skewed, and where we would typically experience a dopamine response and reaction to food telling us that we're safe and ready to eat, now we are experiencing pure fear, right? So what we have to do is continuously rewire our neurobiology. And this is a larger conversation. However, the point that I mentioned in this presentation was that when we are malnourished and we are feeling those effects in our brain, the anxiety and depression is very common in conjunction with the malnourishment, because of the malnourishment, not because of the eating disorder. But if we are not eating enough, our body has a very difficult time making those feel-good hormones that we need so much, which are dopamine and serotonin. And those hormones use lipids as their backbone. So there we have
chemistry there. Good job, Blake. But it's so true, right? If you're restricting too much, then the body can't even make those hormones, and so then your mood crashes, and it all comes tumbling down. Okay. There was a third question, was there, Blake?
There's a few more. How many do you want to answer some more now, or would you like to save them for the end?
If they're relevant, maybe we should move on, and then we'll take a couple more, answer a couple more in a little while. Does that feel okay for our audience as well? I'm going to move on to the next slide. So how do we treat orthorexia? That is a really good question. So first and foremost, Blake, I'm going to walk us through this part, right?
Mhm.
So first and foremost, as you can see from all of these examples, even if our client doesn't end up in a lower weight body, but they've lost weight overall, everyone is struggling with malnutrition, inadequate intake, inadequate fuel, neurotransmitters are not getting produced, let alone other hormones that help our bodies to function optimally, right? So we have to treat that malnutrition, restore the body weight if it's appropriate. And we do this in a combo of a hierarchy of foods. We start with safer foods first, per what the client feels are safer foods. And I'll show you in a moment what that means. And then a hierarchy of the meaning of those foods, which is a little bit of another nuance that's particular to orthorexia. Goal 2 is a little bit what Blake was referring to earlier. We do an exposure and response prevention therapy. Now, we do this with our regular eating disorder clients anyway, who are fearful of high-fat foods, for example, or fearful of carbohydrates because they'll make them fat. So we do that ERP therapy anyway as nutritionists, but here we're using these specific foods that these clients might feel are toxic, for example. So, and this actually, the ERP or exposure and response prevention therapy is actually based upon an OCD protocol. So we notice similarities between someone who is obsessive compulsive around, let's say, dirt or germs. So, for example, if someone has OCD, they may have a really hard time touching a door handle because they imagine and they see and they almost feel like they can feel the germs and the bacteria on the door handle. And so an exposure and response prevention therapy is to have them actually touch the door handle, but then not do any kind of compensatory behavior to then reduce the anxiety that they would normally do, which would be to furiously wash their hands or not touch the door handle. So the goal is that to show them that over time, nothing terrible is going to happen if they touch the door handle, and it doesn't necessitate, in a very panicked, anxious way, washing their hands immediately. That example, I realize, is completely tone deaf right now because of COVID. However, I hope that you can imagine, pre-COVID, that what that scenario would look like. So we do something similar with the food response, knowing that there's a heightened anxiety response, and we want to reassure the client that actually their worst case fear is not going to happen. Takes time, as you can imagine. Medication can be helpful to treat anxiety. Do know that if the brain is really malnourished, that anti-anxiety medications are not necessarily helpful because the receptors in the brain, if you think of the brain, it has these little docks where the medication docks to. If the brain is malnourished, the receptors are not in a configuration that if the medication comes in, the medication can't dock to then elicit the response. So a malnourished brain is not going to respond well to medication. So as you could therefore determine, the first step is really getting food and nourishment back into the brain, get the brain back online, get those neurotransmitters getting naturally produced, and then you can then add medication to support that, should that be helpful. And then, of course, we need therapy around perceptions and some of the behavioral therapies that are really great. Cognitive behavioral therapy, otherwise known as CBT, rigidity, black and white thinking, distorted thinking patterns. And we also use dialectical behavioral therapy. It's around mood regulation, DBT it's called, ACT, which is acceptance commitment therapy, which is around like radical acceptance and these sorts of ideas. They're very, very helpful and fall under that behavioral therapy modality. And then, of course, psychotherapy and process therapy to kind of get a deeper meaning about what this is all about, self-esteem, family dynamics, etc. So there's quite a series of steps there with some really good outcomes. So when I mentioned about hierarchy of food for our clients with orthorexia, they're thinking about, okay, this food is scary because it's not organic, let's say. This one's scarier because I don't know where it was actually grown. And this one's terrifying because it's actually produced, it's actually a produced food, and it's got all these chemicals that I can't pronounce on the back label here. And therefore, this is the image in the mind. I think of the poison apple, right? That, okay, this is not an organic apple. It's actually had pesticides sprayed on it. So therefore, the client is seeing this as something that is absolutely toxic to their system. So you can see that there's a distortion going on. I'm not saying that pesticides are healthy. I'm not saying that, but you can see that the reaction is a little bit disproportionate. And therefore, that hierarchy of meaning, what is going to go on for the client if they do eat these foods? At the very lowest level, it'll make me sluggish. We often hear this, for example, with carbohydrates. At the next level of, no, I can't eat that food. Why? Because it'll make me sick. It's got pesticides on it. It's not organic. To a whole level of it'll poison my entire system. So you can see a very exaggerated fear level there. And there is an avoidance of the food or a desire to expel them from the body. So meaning is also important, so you get a better sense of what the client is imagining is going to happen to their body. And we've had clients who've said, you know, I know that if I eat this apple, let's say, I can feel the difference in my skin. I can feel the difference in my GI. I know that it's like a cancer and it's poisoning my body. So for the therapists who might be on this call, on this webinar right now, you can see that the anxiety levels are through the roof. So the brain is really kind of starting to not be in a moderate place. So we talked about this exposure therapy. The goal is gradually and voluntarily expose yourself to the source of your fear, and you do that over and over. And for a lot of our clients, they need some coaching here, and so that's where we step in. And the goal is to not act out any of the compensatory compulsions to neutralize or stop the fear. It's to sit with the fear to then know, okay, nothing terrible actually happened after all. So it's a way to learn alternative coping mechanisms to cope with the fear and anxiety, or at least that's part of what we do with our different behavioural therapy skills that the clients learn as well. So we're not just taking away a coping mechanism and leaving them raw with all these emotions, but okay, how else can you soothe yourself? How else can you bring your anxiety down? Through all sorts of different things, from exercise to thought processing to journaling to, you know, group therapy, etc. And then by repeatedly facing something that you're afraid of, you're really forcing your brain to recognize that there is no real threat. It was a perceived threat, but it's not based on reality. So here's an example. A person with the fear of a non-organic food, i.e. those toxins will poison my body, might be asked to go to the supermarket and just look at those foods in the aisle. Okay, we would take them with our staff. And then the next step maybe would be to touch one, or to eat dinner with, you know, I'm going to use an apple, with an apple sitting on the table nearby. So we're increasing time and proximity of exposure to that item. And then from there, the next step might be to take a bite of it. And then over time, fear diminishes. The brain realizes that that non-organic apple is not a threat. And while those fear thoughts may not go away entirely, they're no longer debilitating. And that's the key piece, is to get our clients to a place where they're not debilitated by this obsessiveness around these food items. Remember, guys, a lot of this is biological. Our clients don't choose to be this way nor act this way. This is where this illness, disordered eating and eating disorders, take on a life of their own. Even if we start from a place of good intention to be the healthiest version of ourselves that we can be, it comes from a really good place, and then it can get really wrong really quickly. Mm-hmm. So that's what we're really speaking to here today. Mm-hmm. Mm-hmm. Blake, do I continue here?
You do.
I might have actually did a couple of Blake slides. My apologies, Blake.
That's okay. You got excited.
I did get excited. I'm sorry about that.
There is one thing that I want to add to the ERP, if I can, and that's something that I touched on in a question when I got excited, which was talking about the brain chemistry and how that gets changed in eating disorders and how we work to refire those neurons or rewire those neurons to fire appropriately.
Yes.
So what we're doing in ERP is exactly that. We're reworking the neurons to understand that this, for example, non-organic apple is safe and we can be nourished with it, right? And we are safe after we eat it. So then using those DBT and CBT skills that Mel referenced, that's how we go back into our rest and digest system and like practice being calm almost, right? And that will effectively, hopefully over time, convince the brain that we are not in a fight or flight mode.
Excellent. Very nicely summarized, Blake. I'm so sorry that I kept going there.
Please don't apologize.
I did have a question for you. I saw a couple more questions coming in. I'm wondering if there was anything pertinent to this section before we go into the next.
Sure. Okay, let me look at these.
Yeah.
Can you go back over the litmus test for percentage of day spent thinking about food?
Yeah, sure. So it's actually I didn't include that slide for this deck, but it's just easily you just ask your clients how much of your day do you spend thinking about food, and if the client is struggling with anorexia and worried about calories and body image, I would add how much of your day do you spend thinking about food and calories and weight, body image and exercise. So, you know, kind of broadening that. And also ask them when you're not distracted. So that means when you're not working crazy hours and, you know, you don't have a very packed schedule where you can distract. So if there's nothing distracting you, how much of that is going on? And as we said earlier, the average person, whoever that is, without an eating disorder, it's around 15% of the day. You wake up, you're hungry, you eat, you don't think about food again. You're full, you stop, you move on to the next meal when you're hungry again. But for others with disordered eating or an eating disorder, it could be 50% through 100+% because we dream about food when we're that malnourished. I hope that answers that question. Any others? Yeah.
One that I think is pertinent to us right now is, can virtual food exposure therapy be useful, or is there not enough literature to back it up?
Well, I think that we've been forced to do virtual food exposures because of COVID, and we didn't have any research, so we just had to anecdotally and clinically observe. And we've found that we've been able to make really good progress being 100% virtual. So it doesn't need to be in real life. What we have noticed though, as you would imagine, a camera only allows you to see a certain area. And so for some of our clients, you know, they have broken off part of the food and popped it on the floor where it's off camera and you wouldn't know. But if your clients are being deceptive in a virtual session, that also tells us how ill they are. So it's around level of care as well, appropriateness for care. But the answer I would suggest is it should not stop you from going through, exposure therapy with food and meals. And in fact, it's meal support and exposure therapy with meals, Blake, would you say, has really increased for us over the last 9 months?
Absolutely. I can say firsthand that food exposures and meal support are absolutely working. And we've seen many of our clients enter treatment virtually and discharge appropriately from treatment virtually with a very much widened food repertoire.
Yeah.
And we've had to get a little creative. So for the clinicians on the call, maybe it's asking clients to prop their food up on a pile of books so you can see their plate, or asking them to move their laptop around after the meal. I have no problem asking clients to do awkward things anymore. But it's been a journey, but we've really figured that out.
Yes, Yes, and in extreme cases, we've had a family member sit off camera but
Mhm.
observe the client, maybe an adolescent who's really struggling, to try to help with that accountability and completion. So those are just some tips, right, that we've learned along the way. Yeah, is there another question that might be good to take right now, Blake?
Sure, let me look. Oh, how can you tell when the brain is fully nourished? Or at what percent IBW will the brain be able to produce the neurotransmitters to process the anti anxiety medication? And then there's a follow up question that I can.
The answer to that is we're not sure. We don't, it's really trial and error right now. Here's what I have started to conceptualize as a proxy, to tell us when the brain is starting to really be more fully repaired. And that is, it's quite interesting, but we notice, and this is from the literature, that body image for those clients who struggle with that, so I'm speaking more to anorexia, bulimia, and binge eating order to a degree, um, we notice that body image starts to shift and lessen around the 18-month mark or 2-year mark after consistent food intake. Um, and so, I'm using that as a really quick proxy to suggest that full renourishment of the brain may take that long.
Mhm.
Because we also know that the first year to a year and a half is also the highest risk time for relapse. So I'm wondering whether that a lot of the neuroplasticity and such that we would want to see in the brain with new pathways, literally that we're trying to carve out for our clients, correcting dysfunctional ways of thinking, it may actually take that long with good therapy, good nutrition, for that to become more permanent. So that's what I'm thinking. I have not seen any studies, and I think it would be hard to test for as far as neurotransmitter levels in the brain, and at what timeline are we talking about. But again, as we look at the evidence, as we look at the research and the high risk of that first 18 months, that would suggest to me that all systems are not really back online and fully restored
Mhm.
until maybe that pivotal 18-month mark and even 2 years,
Mhm.
um, which speaks to how essential it is for our clients to stay plugged in to treatment during that time. And I don't mean residential for 2 years at all. I mean, getting a foundation where our clients are able to then consistently have food intake, because that's our first medicine, consistently then be able to do good therapy because the brain is coming back online, and then working through anxiety, working through self-esteem, working through family stuff, working through trauma. And we know that not all of that is going to be done and achieved and perfect after 18 months. In fact, we know it takes a lot longer than that. But as far as that brain repair, that's my
Mhm.
not, I wouldn't say it's a guess because I think it's based upon what we're seeing in the research, but that would be what I would suggest anyway.
Mhm. Yeah, and I would also add to that that as the clinician working with the client, you can often ascertain when the brain is not online through conversation. Perhaps the cognition is jarbled, or they have difficulty finding their words. There's a focus on food or a focus on stressors that is not able to be quelled. And I'm saying that because the next question was, have you experienced doctors or psychiatrists being aware of the brain not being fueled and medications not working?
No, no, it's actually um, disappointing. But I don't know that it's disappointing per se. But here's the thing in our field, in the healthcare and mental health field, because for so long eating disorders, if you look at prevalence that has been reported in the literature, the prevalence has been so low, it's been underreported. So by
Mhm.
default of that, none of us in the healthcare and mental health field get any training in eating disorders. So our MDs, our psychiatrists, our registered dietitians, our therapists, we realize now and we understand now that the prevalence is actually a lot more than we thought. And in fact, latest estimates, lifetime prevalence rates are around 10% of the population. More women will struggle with an eating disorder in their 50s and above then will develop breast cancer. But no one hears these statistics, right? Because there's very little money spent in our field on research and on public health education. And certainly the healthcare professionals that should be guiding clients are not getting training. So therefore, that was a long answer to say that most psychiatrists do not understand malnutrition. Well, they understand malnutrition as a concept, but because most people coming in with anorexia or bulimia or binge eating may not look like someone who is going to die of starvation, then they're not thinking about malnutrition. And as we said, it can be very subtle and not so subtle, but we know MRI where we get to actually see a malnourished brain. There are bigs in the brain. So we know it's happening. So therefore, you as the potential eating disorder or disordered eating specialist, or at least someone with a little bit of knowledge, you may actually be the one who might be guiding the psychiatrist on the team, or the MD or the therapist. So that's a tough role as well. Did that explain? We've got a lot of questions coming in. Go ahead, Blake.
Yeah, I think that explained really well. We do have a lot of questions coming in. However, I'm also aware that we only have 15 minutes left of our webinar. So do you want to move forward with slides, and maybe hopefully we'll have time for questions?
Yep, I'm going to finish up the last part, which is really from orthorexia to veganism. And I thought it was important to link these two, because veganism in the last 2 or 3 years has become the #1 food trend. And so much so that, we actually developed a protocol to be able to treat clients who come in who are saying, I will only come to balance for treatment if you're willing to honor my veganism. And so we had to figure out a way to do that ethically, but also to make sure biologically we could actually help our clients restore their brains on a vegan diet. And we figured out a way that we are able to do that. But there is a connection, guys. So this is what I think is going on here. I was really thinking about how did we get to this place of absolute food purity? And really, if you think about it, from the 80s is when the 70s is really when this diet culture thing started really kicking up. Like my grandmother, I remember she used to drink Tab, which is the first sugar-free cola that came out. And so we started out with this kind of fat-free. That actually was kind of a big thing, no fat, as a way to help people lose weight. And we saw that people actually gained weight eating fat-free products, which was not what people thought, because there's not satiety when you take out fat out of a diet, so people eat more. Then after that, we moved into that sugar-free and low-carb Atkins. Like when I first came to the States 20 years ago, Atkins had just re-released his next edition of Atkins. And so that was really big. Take out the carbs. We don't need carbs. And then it all became protein and fat. And people lose weight on that because they get taste fatigue, flavor fatigue, and then they end up binging on carbohydrates. So that's another form of macro, changes. Meat was still prevalent around Atkins, but then we started to move away from the meat industry. Still high protein, but more vegetarianism, which has led to veganism, and then on to, the purity around no GMOs, and certainly everything being organic. And also just knowing a little bit more about how our food is produced, which brings me to our next slide, which is these kind of 3 elements on the left-hand side. We've had this state of the nation, and sorry, I'm using medical terms here that are used. We don't like to use the word obesity anymore, but it is kind of what the medical field, unfortunately, and also society embraced. State of the nation, obesity, it's not healthy. Along with the next blue arrow here, this idea of transparency of our food industry practices, which I think most of us were terrified and alarmed to see. Hormones, antibiotics, toxins, and of course, animal cruelty, and now environmental issues. So a lot of concern around that, followed by then social media. And social media is the idea of a curation of this happy, unhealthy, unbalanced life, and also the how-tos. So very, very easy to like, how do I do this? How do I become vegan? How do I do this? And you'll see here social media from Google search coming out in 98 right through to TikTok from 2018. And, you know, it's interesting. Instagram now has been around for at least 10 plus years. But they're very influential in the messaging that we get. Now, all of this packaged together is also combined with a movement from, for example, my grandparents' time where, you know, you lived life, you got sick, the doctor said, cut out cholesterol and start walking. And so then for treatment of an illness, you started to then, you know, follow the doctor's guidelines. But then the next generation were like, we don't want to get sick in the first place, so let's be preventative. And that's really my wave and my generation, and why I became a nutritionist was really about this idea of prevention. And as a society, we've embraced that idea of illness prevention, longevity, disease-free, etc. So that's part of kind of where we are now and why we're so uber focused, therefore, on our food. It makes sense, right? And it is good, and I think there's a lot of great elements until it gets obsessive, and that's really what we're talking about today. And this is just an example of we know social media is impactful, we know this. But check this out, guys. Look at the little purple ones. This is gluten-free. I know that this is a couple of years old now, but the example is still very relevant. So we're looking at the purple, right? You can barely see any purple in there. This is actually gluten-free diets. This is Google searches. 2009, Google searches for gluten-free. You can see there's a lot of it. 2011, 2 years later, it's kind of grown a lot. To 2015, most states, most people throughout the US are Googling gluten-free. So again, just one visual example of how an idea, a concept, orthorexia, veganism, can then just become like wildfire, and then everyone's doing it and they may not necessarily know why or the pros and cons. So that's where we're going to wrap it today. We're going to take some questions. Blake and I have included our email addresses there for you. For anyone who's on today, you certainly can get a link to this webinar by the end of today onto our YouTube channel, so you can check that out. I also wanted to let you know that there's some additional resources here, our own blogs, and also our website, Redefining Wellness, which looks more around disordered eating than full-blown eating disorders. We also have an amazing non-diet book that is free that you can download from this link here. And of course, please do follow us on Instagram, where you won't get inundated with diet culture messaging, but quite the opposite. I also want to let people know that we have an intuitive eating group on Thursday evenings with the wonderful Chloe, so check that out. And also, if you're looking for more resources, we have lots and lots of groups. We have programming, we have one night a week groups, we have individual nutrition services as well. And you can also book an admissions call with our team, a free 20-minute call. So I'm going to leave it on that slide while we go through our last questions, Blake.
Awesome. Thank you very much, guys. Okay, so this question is from our lovely Emily. Hey guys, do you find a differentiation between an orthorexic client's relationship with exercise versus someone with anorexia? Or is orthorexia strictly related to food intake?
Yeah, as of right now, orthorexia is strictly related to food intake. If a client, but it makes sense that part of optimal health would also include activity. And so a client who can get obsessive about food is genetically wired to also maybe get obsessive around exercise as well. But for the purposes of the definition of orthorexia, we're talking specifically around their relationship to food.
Okay. Oh, here's a question. I'm going to take this question if you don't mind, Mel, because
Yeah,
I'm excited about it. This person said food addiction is getting more attention right now as well. What are your thoughts on food addiction falling under the umbrella of OSFED? So my answer to this question is that yes, food addiction has been getting a lot more research lately, and a lot more attention in the media, I think, as well. There was the Yale Food Addiction Scale that came out and some other things. However, when you really delve into the research, there's a lot that concerns me when looking at that. And the first thing is that we need food to live. Our body needs glucose. Our body needs, in order to function, we need food. And a lot of the measures that they were using, such as the dopamine response when we are eating, being similar to that of, I think they used cocaine, I think is what they used, right? But we also see that similar dopamine response when holding a baby or hugging a loved one. So there's really a lot to be left up to interpretation there. And the second thing is that I want to emphasize is that when we look at addiction, we typically see people who are addicted to things such as drugs requiring a higher dose response because they become used to this thing and it no longer gives them that dopamine. But that doesn't happen with food. We don't need a higher response of Skittles in order to feel happy. We just enjoy them. So I don't perceive food addiction to be an eating disorder, and I don't perceive humans to be addicted to food. Um, I'll let Mel follow up
Exactly.
on that as well.
Exactly, Blake. Yeah, there's been some misinterpretation, I think. And also, if you think about it, guys, you know, the substance use industry or field and treating substance use has been around for a lot longer than the eating disorder
Mhm,
field.
mhm,
And so when our field started looking and identifying eating disorders, um, we adopted and took a lot of the tools and approaches from the substance use industry because we didn't have any of our own. And then over time, we've determined what of those are applicable and what of those are not. And because there's like a 50 or 60% crossover between those who struggle with substance use and those who struggle with eating disorders, it makes sense that people think, well, 12-step worked for me here, so why can't it work for me with food? Because I binge on carbohydrates. But as Blake rightly said, you know, sugar is supposed to give you a dopamine response because it tells you that it's fuel for the body. But the difference between, and so does cocaine, right? And so does alcohol, it all hits the same reward system. But the sugar is actually absorbed into the cell to fuel the cell. Whereas cocaine and alcohol, when they hit the cell, it's toxic. They actually damage the cell. So that's one big difference. And also the study that you're mentioning, Blake, that looked at the idea of binging on carbohydrates. If you actually provide people with consistent access to carbohydrates, they might binge initially, but over time, they lose that dopamine response to carbohydrates. So
mhm.
there is some thought that there might be a small subset of people who maybe have some kind of really unusual response to sugar, but it does seem to be not as common as what I think society's led to believe.
Yeah, yeah. Food addiction kind of demonizes food, and what we want to work to do is do the opposite, include food
Exactly.
as one of the thing that gives us life. And food addiction or binging is often in response to restriction. Absolutely.
Yes,
Yeah,
exactly, Blake.
yeah.
Exactly.
Okay. Oh, this is a good question. I'm a mother of a teen going down this path. How can I get her to admit or accept that there is a problem that she should get treatment?
It's really hard. And that's where it may be helpful to talk to a professional or maybe bring her in so that we could then work with her. And, you know, if you think about those check boxes that you went through, Blake, that you walked everyone through, it's a really great way to assess and maybe ask your daughter, you know, do you feel that this is giving you adequate nourishment? But remember, it's very egosyntonic, which means that your daughter is going to think that this is a good thing that she's doing and she's not going to see it as damaging. So that's where it's really, really hard.
Mhm.
Blake, you've worked with some of our adolescents. Maybe you have some suggestions there?
Ah, gosh, it's so tough, and I really feel for you because, like Melanie said, it is very, very difficult. I think reflecting back to your teen that you're concerned for them, and that you do not want to like change the way that they're eating because, like you said, it is egosyntonic. But you're maybe reflect some of the things that you've noticed in their mood or in their affect that may be ego dystonic that might help to call attention to the behaviors.
Yeah, absolutely.
Mhm, mhm. There's one question. I think we only have time for one more, but I think this one is exciting because it says that I am a counseling psychology master's student looking at researching the psychology of orthorexia for my thesis. What area of research would you say is lacking, and what would be most useful and informative to your practice as dietitians working with orthorexic clients?
Whew. All of the above. Go ahead, Blake. What are your thoughts?
Oh, everything. Let's see. I'm thinking perhaps the first and foremost treatment, right? Because we have the ERP, which is so important. However, we don't have a specified treatment for orthorexia rather than other eating disorders. Um, and perhaps the development of orthorexia and how it goes from healthy eating to something different.
Yeah, I think the bottom line is that we just need research, because as you know, an eating pattern or an illness gains more and more research around it, then we can move towards doing studies towards evidence-based treatments, to looking at then you know, success rates of said treatment. So your contribution through doing your thesis to the body of research around this would be a really important step.
Mhm, mhm, mhm.
And I think that's all we've got time for today, guys. It's 1:30. We had a lot of questions, which is really exciting. I hope we got to answer some of the main ones for you. And I want to thank my co-presenter today, Blake, for joining me on this wonderful topic around orthorexia, because it's so prevalent, guys. It's so much more prevalent because it's so normalized in our society.
Mhm.
So I hope that was very, very helpful to you. You've got our email, so if you wanted to reach out, please do. And also, if you or a loved one may need some more support, please give our admissions team a call as well. Thank you so much.
Thank you. Thank you, everyone. And thank you, Mel, for having me.